Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted so you can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's program, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I will introduce you all to today's guest speakers. Joining us today, we have the Mass General Sexual Health Clinic team. Joining us, we have Vitor Cardoso. Vitor has been a nurse practitioner for 10 years and is a strong believer in health equity. For most of his career, he has provided care to vulnerable and underserved populations, which has now extended to HIV screening and prevention through the Sexual Health Clinic. Joining us, we also have Emily Pariello. Emily is a women's health nurse practitioner who has worked at the Sexual Health Clinic for the last 2 years. She's extremely passionate about empowering patients to make the best decisions for their own care. In her role at the Sexual Health Clinic, she is dedicated to eliminating barriers to HIV care and prevention. Lastly, joining us, we also have Daniel Kong. Daniel is passionate about health equity and public health and has been working in the field of sexual health since college, where he was a peer educator. Now, as a clinical research assistant at the Sexual Health Clinic, he hopes to continue to better understand the nuances and challenges of this field to improve health outcomes in marginalized and underserved communities. In recognition of National HIV Testing Day, they join us today to give a talk on HIV awareness. So please join me in welcoming them.
Everyone, thank you so much for joining us and tuning in. Today we're going to talk about HIV and compare it to what it used to be and what it's now. And it will be a very casual conversation. And yeah, thanks again for joining us. So just going over a few of the things we're going to talk about. So we're just going to do a quick overview on HIV, what it is exactly, and how it was initially viewed back in the 80s to what it is now. Then we'll talk about post-exposure prophylaxis, pre-exposure prophylaxis, and HIV care, treatment. We'll talk about some misconceptions, and then compare those to the actual facts about HIV. We'll talk about why you should get screened and what you can do to prevent HIV and what assistance are available. And then we'll talk about the future of HIV, what might be to come. So HIV, as most of you might know, was a big problem back in the 80s. That's when it started to affect communities, and most specifically the LGBT community. And it was, at the time, it was considered to be a gay disease. And then eventually it started being referred to as AIDS. It wasn't until the mid-80s that the term HIV was actually used. At the time, having HIV was almost fatal. A lot of people lost friends and family from HIV. And eventually in 87, the first HIV medication became available, AZT, which was a game changer, but they were very hard to tolerate, and it was a very tough medication, and that too has changed over time. So what is HIV? HIV is a virus, and it kind of attacks your immune system, most specifically white blood cells called the CD4 cells. By replicating, the virus actually enters those cells and destroys them. It's also very hard for your immune system to fight it because the virus is constantly changing and mutating. And by doing so, then people with HIV and treated HIV, their immune system become very weak. And a lot of times that will lead to other infections. And really what usually kills people with HIV and AIDS, it's other infections because your immune system is not able to fight them. So something as simple as the common cold could turn into pneumonia, or fungal infections could get much worse than in a healthy person. HIV could eventually lead to AIDS if not treated. AIDS occurs when the number of CD4 cells goes below 20. Another something that would also would make you have AIDS or consider you to have AIDS would be when you develop opportunistic infections, regardless of what your CD4 count. So what are some myths about HIV? So, like I said, in the 80s, because it was significantly affected the LGBTQ community, it was called and still sometimes sought as a gay disease, and that's absolutely not true. HIV affects people of all races, sexual orientation, identity, social economic status. Another misconception is that people on monogamous relationships don't need to worry about HIV. That's also not true. Everybody should get tested. Even couples before they become monogamous should get tested, maybe go together. A lot of times, in fact, most recently, about 68% of new HIV infections were for people who were in relationships but had a boyfriend or a friend with benefits. So it's very important to know your status regardless. Another misconception is that you can tell someone is HIV positive by the way they look. That's absolutely not true. People with HIV can live very healthy, long lives nowadays. So if somebody does look sickly, it doesn't necessarily mean that they have HIV or AIDS. Another misconception that comes from the, back in the day, 80s, 90s, when people would die from HIV and AIDS, is that HIV is a death sentence. That's, again, absolutely not true. People with HIV can die from anything else, from a heart attack or cancer or old age, not from HIV. Another misconception is you can easily contract HIV from someone who is positive. Also not true. Somebody who is HIV positive and in treatment are usually undetectable, meaning their viral load is so low that a lab test cannot detect it, and therefore making it nearly impossible to get HIV from them. Okay. And another misconception is that you cannot contract HIV from oral sex, and in fact, even though that's lower risk, if somebody has a cut on their mouth or some sort of ulceration and is exposed to HIV, the body can enter the virus can enter the body through a break in skin or the oral mucosa. So other HIV facts is that the virus is actually very fragile and it can't live for too long outside the body. So usually HIV is transmitted from blood to blood or through body fluids. Another fact is that HIV cannot be spread through saliva, so it cannot be spread through kissing or using utensils, hugging, shaking hands, sharing exercise equipment, and my favorite, using a public toilet. Another fact is that HIV, like I said, HIV affects people regardless of sexual orientation, gender identity, race, socioeconomic backgrounds. All right, so why should you get treated? Anybody, screened. Basically, anybody who's sexually active should get tested for HIV and other STDs, really. Something that puts you at a higher risk for HIV is having anal or vaginal intercourse without a condom, or with somebody who's or an unknown partner, not knowing their status and not being on medication to prevent HIV called PrEP, which we'll be talking about that later. Another reason to get tested is having multiple sex partners, only because the more people you have sex with, the more likely you are to be exposed to an STD, including HIV. Another indication for getting tested is if you've tested positive for chlamydia, gonorrhea, syphilis, herpes, or any other STIs. Only because if having another STI can put you at risk for HIV. An STI like syphilis or herpes can cause an ulceration or a blister, open skin, and then will make it easier for the virus to enter your body that way. Chlamydia, gonorrhea, it also jeopardizes your mucosa. The mucosa is more sensitive, it's irritated, it makes it also making it more easy for the virus to enter the body that way. Another reason to get tested is if you're an IV drug user, especially if you share needles. Also, alcohol and other illicit drugs can impair your judgment, and then you might engage in condomless sex or any other behaviors that could put you at risk. Other methods of transmission that are less common is if someone's positive and pregnant, it's possible to pass HIV to a baby, even though if the person is treatment, though in treatment, it would be the person will be monitored and very unlikely to happen. Another way is blood transfusions. Nowadays, that's also nearly impossible because that it gets monitored and tested, blood get tested, and percutaneous. Somebody gets a needle stick from somebody who's positive, but again, that's lower risk. So HIV treatment, we won't go too much into treatment, but there's a lot of options for someone who's positive and who's in treatment. Treatment for HIV, it's called antiretroviral therapy, also known as ART. People can take pills every day, a single pill or sometimes a combination of 2 or more different medications. And now there's also treatment injectable medication. There's Cabenuva that's every 2 months, and there will also be another one that's every 6 months. And again, if people are in treatment and doing well, they're considered undetectable, meaning that their viral load is so low that the lab test cannot detect it, be detected, and that and therefore intransmittable. And that's where the term U equals U comes from. All right, so that will lead us to post-exposure prophylaxis. So if someone has an encounter, whether it's a sexual encounter or any other type of exposure to HIV, they can take medication to prevent an infection from happening. And the medication that we use, it's actually HIV medication. It's just taken differently to prevent an infection. So post-exposure prophylaxis, it's also known as PEP or NPEP. And again, it's medication that we have to take as soon as possible, ideally within 72 hours of an exposure. In our clinic, we usually do Truvada and TBK once a month for 28 days. Another option was Truvada and Raltegravir, but we usually like to do Truvada and TBK because with Raltegravir, you have to take it twice a day, and it's just easier for people to take just 2 capsules once a day rather than take 2 in the morning and 1 at night, or vice versa. So we might be getting away with that, and soon we might be able to just use Biktarvy once a day for post-exposure prophylaxis. Some of the other things we do on the first visit for PEP is we do baseline screening. So we'll initially test you for HIV, make sure you are absolutely negative and that you actually didn't have it before your possible exposure and didn't know. And then we also test you for other STIs like Hep C. We do hepatitis B serologies to make sure you don't have an active infection. We test you for syphilis, chlamydia, gonorrhea, and if indicated, we'll do a pregnancy test. And we also check your kidneys and liver, make sure your organs are nice and healthy before we put you on your medications. If you think you might have been exposed to other STIs, we can also treat you empirically, like chlamydia, gonorrhea. And then we check in again in 2 or 4 weeks just to see how you did with the medication, if there was any issues. and then we'll repeat all those tests. And that will lead on to PrEP, pre-exposure prophylaxis.
Yes.
So here you go, Emily.
Oh, thank you. So I'm here today to talk about PrEP. PrEP is an amazing medication. It's widely available and it's highly effective in preventing HIV. PrEP, if taken correctly, reduces the risk of contracting HIV through sexual activity by about 99%. PrEP, if taken correctly, can also reduce the risk of HIV from injection drug use by at least 74%. And so PrEP is similar to PEP in the sense that we're using antiretroviral therapy medication preemptively before an exposure. So the difference between PrEP and PEP is a medication you take after an exposure, but PrEP is a medication you take daily beforehand to help build up the immunity. To be used correctly, it has to be used for about 7 days before it can be counted on for HIV protection. HIV exposures can either be through sexual activity or injection drug use. PrEP is for everyone, but some people that PrEP most benefits would be men who have sex with other men, transgender women who have sex with men, people who have sex with or share drug equipment with HIV positive partners, or people who share needles or drug injection equipment with other people in general. Important to note that PrEP does not protect against other STIs nor pregnancy. So we do encourage using sterile needles, sterile syringes, condoms, birth control, anything like that. There are multiple different forms of PrEP, and so there are 2 oral medications, Truvada and Descovy. Truvada has been around a little bit longer than Descovy, so there is also a generic version of that. With Truvada and Descovy, you do need to take the medication every single day. The injectable medication, cabotegravir or Apretude, is a new-ish medication. We do it often in our clinic. With that, you come in every other month for that. And so it's a good option for patients who do not want to take a daily pill or have issues with compliance or anything like that. I also love talking about PrEP assistance programs because there are so many ways to get PrEP if you want PrEP. And so Massachusetts has a good PrEP assistance program called PrEPDAP. PrEPDAP helps eligible Massachusetts residents pay for their medications. This can be for a variety of reasons, whether you don't make enough money to help pay for it, or the copay is too high, or one of my favorites is that it also helps patients who are on someone else's health insurance and don't want to use their own health insurance for confidentiality reasons. And so with PrEPDAP, what we do is we submit an application with you on your behalf, and then PrEPDAP covers the entire cost of the drug for any confidentiality concern patients. And so PrEPDAP is an amazing program. They also have a program called HDAP. HDAP is helping cover the cost for out-of-pocket costs for prescriptions for HIV, hepatitis C, and other conditions for people living with HIV. HDAP, the immigration status does not affect your eligibility for this program, which is amazing. HDAP is, you can also do the application either yourself or you can do it with the assistance of a case manager. But PrEPDAP and HDAP are both working towards eliminating any of this cost barrier or anything that should prevent people from getting the medication and the care that they need. This is just a comparison of HDAP versus PrEPDAP. And so if you have any questions about HDAP or PrEPDAP, or you think that any of this applies to you, or you have any cost concerns, it's always good to reach out to your healthcare provider and see if they know about any of these like programs or benefits assistance or anything like that. There's also a program called Ready Set PrEP. And so Ready Set PrEP is a federally funded program which provides PrEP to uninsured individuals. To do Ready Set PrEP, you must not have any other health insurance. You must have a prescription for PrEP. You must be HIV negative, and you must live in the United States. And so the difference between PrEPDAP and Ready Set PrEP is that PrEPDAP is a Massachusetts specific program, while Ready Set PrEP is a national program. And so we often have patients who might start Ready Set PrEP with us and then move somewhere else in the country, and that's something that they can still do while on Ready Set PrEP. Also, PrEP in the Affordable Care Act. So oral PrEP was given a grade A recommendation from the US Preventative Services Task Force, which means that there is a high certainty that there's benefit from providing this service. So under the new Affordable Care Act, most new health insurance plans must cover certain recommended preventative services, including HIV testing, with no cost sharing to the patients. With that being said, I always recommend and encourage patients to make sure that they're not getting billed incorrectly. And if you do have any problems or any questions, or you think that something isn't right, you should always reach out to your healthcare provider and have them look at it with you, or your benefits coordinator, or whoever is working with you, to make sure that you're getting the PrEP care that you need and it's not something that you shouldn't be getting billed for. Then there's also PrEP in the Patch Act. So the Patch Act is protecting access to confidential healthcare. This is also be in a situation where you might be covered under someone else's health insurance. And so when patients receive healthcare, they often receive something called an explanation of benefits. And so what you do for the Patch Act is that you call and you request that the Patch Act be enforced. And then basically, instead of listing exactly what services or care you're getting, it does list the sensitive encounter as a more broad description. And so sensitive encounters, not specifically limited to HIV, but including HIV, would be HIV testing or treatment, PrEP or PEP, any mental health care, any alcohol, tobacco, or drug treatment, gender affirmation or transition services, birth control or pregnancy tests, any sexual assault or domestic violence related services. So if you have an encounter that is more of a sensitive or confidential care, you can always call your health insurance and enact the Patch Act. And so information you need for the Patch Act would be your health insurance plan name, the policy number, the member or customer service number, and the name and the date of birth of the insurance subscriber or policy holder. A lot of this information is available on the back of your insurance card. And so I also have included a script about what to say for the Patch Act. This is just a broad script. You can find information about it online. But basically what you do is you call, you give them your insurance information, and then you say that under the Massachusetts Protect Access to Confidential Healthcare Act, I'd like to request that my explanation of benefits be sent to, and they can either send it to a different mailing address or they can give you an email address. And so it's just a great option for anyone who doesn't want to have their confidential information shared under someone else's health insurance. And so that leads me into Daniel, who will be presenting some information about some data.
Hello, everyone. So I'll be discussing some of the trends and data and statistics regarding HIV in the US. So starting in 1981, when HIV was first, discovered in a large setting, there were about 20,000 new HIV infections per year. And so incidents, as in like new infections, have reached a peak in 1984 and 1985 with over 130,000 new infections a year. And luckily, because of the advent of new medications and treatment options, as of 2021, it has declined slightly to about 32,000 new HIV cases, and we'll explore that in more detail later. But since the FDA approval of PrEP in 2012, there's also been studies that kind of show an association between increased PrEP coverage and usage and increased rates of new HIV diagnoses in certain states. Okay, so right now we want to talk about a little bit about the groups that are disproportionately affected by HIV. So there's this federally issue, like a national HIV strategy plan, and it highlights 5 priority populations that are disproportionately affected by HIV. It includes gay, bisexual, and other men who have sex with men, in particular Black, Latinx, and American Indian and Alaska Native men. It also includes Black women, transgender women, youth aged 13 to 24 years, and people who reject drugs. And I just want to keep in mind that when we refer to men or women in our presentation, we mean those that are assigned that sex at birth, unless we otherwise specify. So, and we also should keep in mind that a lot of these population groups may intersect, and that can also affect them even more as disproportionate. So I just want to give a little bit about HIV data in context of everything else we've talked about. So according to the World Health Organization, about 39 million people worldwide are living with HIV. That's about the same amount of people living in the entire country of Canada. However, HIV prevalence also varies among different demographic groups around the world. For example, in the US, LGBTQ plus individuals may be more affected by that. But in other countries like South Africa, a majority of those who are disproportionately affected are women. So in the US, based off of data from the CDC, about 1.2 million people currently live with HIV right now. And to kind of talk about these disparities, Black and African Americans account for about 40% of new HIV populations, despite being about 12% of the US population. And Hispanic Latinx individuals account for about 25% of new HIV infections, despite being about 18% of the US population. And among, going back to that idea about intersectionality, among Black African American women, the rate of new HIV infections is also 10 times that of white women, 4 times that of Latinx women. So to continue with a little bit about more data, there are certain more population subgroups that are disproportionately affected. For example, gay, bisexual, and other men who have sex with men, or MSMs, count for about 70% of new HIV infections, despite representing only about 2% of the US population. And 25% of these new HIV infections were in Black and African American LGBTQ+ men, and 22% of these new HIV infections were in Hispanic and Latinx LGBTQ+ men. So about 0.4 of the US population also identifies as transgender, and see through CDC data that transgender and other gender identity individuals account for about 2.5% of new HIV diagnoses in the US, with the most in Black and African American transgender women. And people who inject drugs also account for about 10% of new HIV diagnoses in the US. So I just wanted to show you a little bit of the graph from the CDC. So it kind of shows you about how there was about 20,000 new cases back in 1981, and reached a peak of about 130,000 new cases per year, 1984, 1985. And we can see that it kind of decreases a little bit. And then around 2007 was when they kind of changed their data reporting statistics. So there's a little kind of break there, but we can see that there is a continual decline, which generally is a good sign, but they're a little more nuanced than that. So we can go to the next slide. If we see the breakdown by race, we see that it all, ever since it started and at the peak, the racial demographics of whom HIV affects has kind of changed. We can see that at the peak, it seemed like most white non-Hispanic individuals were the most affected. However, as we see to the present time, we see that the most that are affected right now are Black and non-Hispanic individuals, and white individuals have now had the lowest out of these three combined, just to kind of show the shift in demographics of how HIV affects different populations throughout the years. So there are certain initiatives that are, I guess, federally funded, and one of them is the Ending HIV Epidemic, or EHE. And the goal of this is to decrease new HIV infections by 75% by 2025 and 90% by 2030, as well as improve health equity. So currently for every 100 people living with HIV, about 87 know their status. But there are some challenges to this, because as we mentioned earlier, there are certain population groups that are disproportionately affected, such as Black, Hispanic, Latinx populations. Even when you look at certain geographic areas, they are not all, the rates of acquiring new infections are not the same. So for example, 52% of new HIV infections were in the southern US at a rate of about 14.7 per 100,000 people, whereas the Midwest region has the lowest rate of new HIV infections at 7 out of 100,000 people. You can see that that's quite a big difference. So despite these different advances, which are benefit a lot of people, there's a lot of disparities that still remain. So as we mentioned, PrEP is a very important tool in preventing HIV acquisition. But then PrEP uptake was only seen in about 23% of those who would benefit most from it as of 2019. However, if we look more into that, we can see that among those who would benefit most from PrEP, racial disparities still remain in the amount of in the percentages of the PrEP prescribed in each group. For example, 63% of white individuals who are who would benefit most from it were prescribed PrEP, whereas we only see that in 8% of Black individuals and 14% in Hispanic Latinx individuals. So just right now, we're just going to talk about potential futures of the prevention and current research. There's some studies going on regarding HIV vaccines, which can kind of instruct your immune system to kind of induce this HIV-specific response to prevent the infection from taking hold. There's a potential cure for HIV through the use of stem cells that have undergone various mutations that don't allow the virus to enter the cells, and potential gene editing may also possible through inactivating certain viral genomes and or by removing integrated viral genetic material from the host. But these are all still kind of in the works, and they're not very much available. But we hope that not only will these be able to take hold soon, but also be able to be accessed by everyone. So from now on, from here on, we just want to talk about some key takeaways that Emily will
Okay.
us.
So some key takeaways. A big thing that I want to reinforce is that the message of U equals U, or undetectable equals untransmittable. HIV care has progressed so profoundly since the 1980s, and people who are diagnosed with HIV now can live very long, healthy lives. For many people, HIV treatment can be as simple as a once daily pill or every 2-month injection. And so I also want to just give a little plug to our clinic and also our amazing colleagues who work in IDA. HIV is readily preventable with PrEP, and it is easy to access in both IDA and with the sexual health clinic. So what can we do? And so this is just a call for action for all of you. What we can do going forward. So we can work to remove the stigma surrounding sexual health and HIV care. We can remove the stigma surrounding sex practices, testing, and substance use. So I'm encouraging all of you to have conversations with your partners, with your friends, with your family. Like, the more that we talk about this and the more that we actively work to remove the stigma, the more accessible care will be. With that being said, you can always look for resources in your community, whether that's on your own or with the assistance of a healthcare provider. It's okay if you don't know where to look, and it's okay if you don't know what the best next step is. The good news is that there are great resources out there, and so it's our job to help you, and it's our job to help you get the best care you can do. And so I hope that you all leave feeling empowered to use these resources or use the people in your life who can help you find these resources. I also want you to all find a provider that you can trust who will advocate for you and with you to do the best care for yourself. So much of our healthcare is finding a provider who listens to you, who lets you vocalize your own concerns and then works with you to finding what's best for yourself. And so whether that's a nurse that you really like, or a doctor, a nurse practitioner, or PA, or a community health worker, or social worker, whoever it is that you're connecting with, you should utilize those resources, and you should really not settle for someone who doesn't make you feel like you're heard and listened to and encouraged to do the best thing for yourself. And as always, you should always advocate for yourself. You know your body best, you know what's best for yourself, and so you should feel capable of vocalizing specifically what you need. And so basically what we can do is we can all work together, try and eliminate the stigma, try to use the resources. There are so many people out there, like Danielle is saying, who could benefit from these resources. And so I hope that this starts a conversation, whether that's for you or someone in your life. And then if you have any questions, you can always come to our clinics or give us a call. We did list our references here. There are quite a lot of them, so I'm just going to move past that. And at this point, we did want to open it up to see if anybody had any questions.
Thank you all. We are at the end of the session, so if you have any questions, feel free to enter them in the chat. We have a question regarding the sexual health clinic at Mass General. Are you currently accepting new patients? Are you located only at the Mass General main campus? And how can one make an appointment if so?
Yes, we are always taking new patients. And we actually can get people in fairly soon. We usually have openings, cancellations. Yeah, so we can usually get people in pretty quickly. We are in Boston Monday through Saturday. Monday, all day Monday, we have evening clinic until about 6:30, 7 o'clock. Tuesdays as well. Well, Tuesdays regular business
Yeah.
hours, but we're also in Chelsea on Tuesdays. So we have 2 locations on Tuesdays.
Yep.
And then all day Friday, all day Wednesday, all day Thursday, and Thursday also has an evening clinic. All day Friday, and then Saturday mornings.
Yep.
And then we also work with some community partners, so you can also see us there. So some of our community partners, it's Health Innovations,
Mhm.
Bagley, JRI,
Mhm.
MAPS. And MAPS. MAPS is the Massachusetts Alliance of Portuguese Speakers. JRI or GLASS and Bagley, they're LGBTQ plus programs, mostly for youth.
Mhm.
But they do screenings on their own for HIV and other STIs. But then on Wednesdays, myself and another nurse practitioner, we actually are on site and we're able to treat STIs if somebody tests positive. And we're there mostly to either start people on PrEP, follow up, do routine follow-ups for PrEP.
Mhm.
We can also do post-exposure if necessary.
We also have our clinic, specifically the sexual health clinic, has funding through the Department of Public Health, which means that we can offer testing for patients if they don't have insurance, if they can't use their insurance. So they can come, and when they're checking in, they can opt out of using their insurance, and it gets billed through the DPH grant that we have. So there are some limitations with testing, but that would be like something that we could discuss when you're booking the appointment or when you're in the appointment. But there's always an option of coming and not using your insurance and getting the visit without having to use your insurance.
In addition, we also do a lot of community engagement. So
Yeah.
we have like tables and stuff at a lot of events around Boston. For example, our last one that we did was at Boston Pride, where we also gave out mpox vaccinations and a lot of resources regarding
Safe sex.
STIs, free condoms, and all these. So we try to make sure that people have the knowledge and the access to have these
Yeah.
services.
And also, we work very closely with our colleagues in IDA, and I just want to give a shout out to everyone that I work with, because if I don't necessarily know the answer, there are so many good resources, whether that's the doctors or the nurse practitioners or the nurses or the community health workers or anybody. So it really takes a village, and I feel like our clinic is very well connected. And so if we don't know how to help you, chances are we know someone who will.
Thank you. And I had just shared the link to the Mass General Sexual Health Clinic. Before I share this in the chat, can you take a moment to confirm if those are the phone numbers to share for the Boston Chelsea locations?
Yes, let me just confirm the Chelsea one very quickly. Yes, those are both accurate.
Okay. While I enter that in the chat to share with everyone, wanted to ask a question about, you had talked about PEP and PrEP and resources for those who are unable to, like, it's cost prohibitive for them. How about ART for people with HIV? Are there any resources to help individuals with limited access to it because of cost barriers?
Yeah, so one of the programs that I had mentioned earlier, the HDAP, which is like the sister program of PrEP-DAP, it's an HIV access program. And so what they do for HDAP is, if they're obviously like income barriers, and so if someone's over an income limit, then they might not benefit from this assistance. But if they're underneath the income limit, which to the best of my knowledge is about 500% of the poverty line, then they can help apply for like copay assistance or medication assistance, or like assistance for other healthcare related issues related to their HIV. And so that isn't something you could always look up HDAP, like literally the letter H, DAP, Drug Assistance Program. It's a Massachusetts specific program. And so I'm not entirely positive about anyone who might be out of state, but that is an option for HIV assistance. Also, I know that our IDA colleagues do a lot of work with HIV preparations, and so they might be able to help a little bit more.
And also, if someone is in need of, let's say, signing up for insurance, we do have a patient benefits
Yeah.
manager who can sign people up for like Mass Health or
Yep.
some other insurance if needed, and we'll
Yeah.
kind of help them, walk them through the process.
There are also some programs like the medication that we use for PrEP, Truvada or Descovy, like the name brand medication, the actual medication companies sometimes does like a copay assistance card. And so I know that's also the case for some HIV medications. So if you're using like name brand medication, you could often do it by yourself, actually sign up for a copay assistance card, and it helps cover copays up to like 6,500 for Truvada. I'm not entirely sure what it is for Biktarvy, but it is an option that we could look into if the medication is just too expensive out of pocket.
Thank you. We have a question regarding if you have any tips to share on how one can talk to their PCP about PrEP.
You can ask. I mean, most PCPs nowadays, they're familiar with PrEP. I feel like maybe years ago that wasn't the case. But yeah, you can always ask your primary care doctor if they're comfortable prescribing PrEP, or if they're familiar with PrEP. And if not, but you want to keep your PCP, you can always give your PCP our contact information, and then we're happy to discuss that with you with your primary care doctor. Yeah, absolutely. Same goes with other things that we offer in our clinic, like DoxyPEP. DoxyPEP is kind of new, so a lot of primary care doctors are probably not familiar with that yet. But what DoxyPEP is, it's doxycycline, a very common antibiotic. But it's not FDA approved, but it's being used off-label to help prevent chlamydia, gonorrhea, and syphilis. And that's something that we have been providing to our clinic. It's not FDA approved, but there are studies that show that it can help prevent this infection. It's not bulletproof. Chlamydia and syphilis, it protects you about 87-88%. Gonorrhea, it's about 55%. But it is something that the word is out. People are asking about it, and we are offering it in our clinic pretty much to anybody who is on PrEP. If somebody qualifies, quote unquote, for PrEP, then they also most likely they will qualify for DoxyPEP.
I'd say for starting the conversation, like it might be something where you don't feel comfortable or not sure what their knowledge is, but the best thing you could do is advocate for yourself. And so if they don't have the answers, then you could always like seek out answers and then like request to come to our clinic, request to go to a provider who knows more about it. And so the worst that they can say is they're not sure. And the best they can say is, yes, absolutely, I'd love to help you.
Thank you, that's helpful. And for those who are interested to be seen at your clinic, is a referral generally required?
Not
necessarily.
Not necessarily. If patients use their insurance, sometimes it depends on what type of insurance they have. But if they opt out of using their insurance or they can't use their insurance, then they don't need a referral if they're not using their insurance.
Thank you. And you'll see that I had entered in the chat phone numbers to both locations, the Boston and Chelsea one. Apologies, the first Boston location number that I shared is incorrect. Please use the second one that I shared, ending in 2748.
It's not bad.
So let's wait for a bit to see if we have any questions. In the meantime, do you have any final thoughts you'd like to share with the audience?
I was just going to say, and keep in mind that we also work with the community partners, like I was saying, MAPS, GRI. MAPS is in Cambridge. They actually have locations all over Boston, as far as Lowell. They have about 6 or 7 locations right now, I think. GRI, Bagley is in Boston. It's right by Government Center. GRI is there in JP. And Health Innovations, they're also in multiple locations. They're in Chelsea, they're in Randolph, they're in Revere, and they actually have a mobile clinic as well. So you might see them outside the bars or the clubs in Boston sometimes. And they offer testing. And then if anybody's interested in PrEP, any of these community partners can refer you to us. Yeah. Another thing that we're trying to do soon will be teleprep. So if anybody needs PrEP, we might be able to do this virtually. In which you'd have a visit with us virtually. We'll talk about PrEP, and then you just have to come in for the lab work. That's in the works as well.
Upcoming attractions.
Yeah.
How about general consults with your clinic? Are those offered virtually or only in person? Or even the phone? Oh, you're being seen at your clinic? Do you offer only in person, or are those offered also virtually, either,
right
through or
right
through phone?
right now we're fully only in person. And so if we did progress to doing telehealth, I think we'd start with something like PrEP because it's easier to do like the counseling. But if someone's coming in for a problem visit, there are like exams that we have to do and like specimens that we collect during the visit that make it more important to be seen in person. So upcoming attractions, but for now everything is in person.
Yeah, right now I do some virtual appointments. Like if somebody needs counseling about an STI or education, they don't need to necessarily come in person. I have done those virtually. I've also done DoxyPAP virtually for people who do get their labs and their STI screening done somewhere else. I just ask that they somehow send me their results once they're available. And this is when those community partners come into play, because a lot of time if I have a lot of patients that get their testing done through the community partners, but then I'm the one who's prescribing DoxyPAP and PrEP.
The only thing else is that you do have to be a registered patient of Mass General or Brigham and Women's to be seen in our clinic. And so for anyone who is looking to seek care at our clinic, just make sure you're either registered or call patient registration and get registered so we can see you.
Right. The other question regarding your slide deck, you have provided some wonderful resources in there. Is there any way to make that available to anyone who's interested in the copy?
We can figure that out, whether that either be like sending it to you or working with our website and listing some of the resources there. But we can be in contact with you and then we can ship that.
And for those who are interested, feel free to email us at the Blum Center. I'm going to put in the email address. It's pflc@partners.org. And once we have that sorted out, we'd be happy to share that with you.
We are also constantly updating our website with new events and new sources, so feel free to check that out as well.
Okay, so I don't see any further questions, so I think it would be okay to end a few minutes early unless you have any thoughts you'd like to share and add.
I don't think so. Thank you for giving us this opportunity.
Thank you for joining us. This is all extremely helpful. And as I had mentioned today, today's session is being recorded. So if you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. And I'll also enter that in the chat. And I think that's it for today. Thank you so much, everyone.
Thank you.
Thank you so much.
Take care.
Bye.
Bye.